It's now my great pleasure to introduce our speaker, Dr. Moran, who is the director of the Texas Paw Project and is one of the nation's leading experts in Declaw salvage procedures. Take it away, Dr. Moran.
All right. Well, thank you so much for having me to do this webinar. I'm glad you could all join us today. We're going to try to link some fear-free knowledge with evaluating declawed cats. The main focus is going to be some surgical intervention. There's going to be a little bit of medical management as well, of mostly cats that have P3 fragments or bone fragments, but we'll touch on a couple other issues as well. Declawed cats are just not highly researched. I mean, it's getting there. We're getting some stuff out there. So I'm just here to present my experience for you to consider, and you can use as you see fit. There are several ways to refer to what we're going to talk about. Some may say paw repair. I tend to use the word salvage just because we can't really repair what we took away or what has been taken away. We can only salvage some function, try to manage their signs if they have chronic pain or something like that. So whatever you call it, I tend to go with salvage. Repairs another term as well. So just an overview. I know anatomy kind of gives people some PTSD. So I'm just going to touch on it, some anatomy details, the nail and the cats. It will be helpful, I promise. We'll touch on some physical exam findings, variations in radiographs, medical management, surgical management, expected recovery of the cases, and we'll go over a couple cases too. If we run out of time, again, you can contact us or contact me afterwards anytime. Okay, so just briefly, this is the P3, the distal phalanx. The orange dotted line is pointing to the root of the cornified claw sheath. This is where the nail grows from within the P3. And then the nail on the top, it shows on the bottom where it fits into the bone. The living epidermis can produce different types of tissue, and it is kind of simplified, but it's located at several different points within the P3. So the little stars show that. The portion of the bone that is in direct contact with the digital pad is the red arrow. It's the articular base. It's oblong. We'll get to why that's important in a minute. And then the unguicular hood and the articular base start to ossify at 6 months old. So also keep that in mind as we're going through this. This is just some examples. The red lines are showing some common places where they're cut through when people are doing partial amputation or sometimes even accidental. Like I said earlier, starts the unguicular hood and articular base start to ossify at 6 months old. So it's completely in the realm of possibility that a CO2 laser or a blade could cut through that flexor tubercle or the articular base, and possibly even the unguicular hood or the through the nail itself. So it is possible. Ossification is complete from anywhere from 12 to 24 months, depending on when the bone face or the growth plates close. So these are some pictures of normal paw pads that are on cats that are not declawed. Oops, go back. They're smooth, symmetrical, uniform in color, and they're oblong to cover that oblong shape of the articular base of the bone. And this is what they're walking on. Here are some pictures of declawed digits. You'll see that they are smaller, they're atrophied, they're ulcerated. They can get calluses on them that can progress to something like a horn, cutaneous horn that happens to. And sometimes they're even positioned closer to be, should say, metacarpal pad, not metatarsal. It could be metatarsal if it's the back leg or the hind legs, but up here in the right, I just kind of put this little orange orange dealy here to represent the paw pad. That's where it normally would be. And then these couple of little diagrams are showing some examples of what can happen when that end of that P2 does not adhere to the paw pad. So it can be positioned behind the bone, in front of the bone, partially. And so they're not walking on the pad. It's bone to skin to ground. Okay. And then these photos are showing some cats with large P3 fragments. I'm sorry if I didn't make that clear. This slide, it's either no P3 fragments or small ones. This one is large P3 fragments, and you can tell because, well, obviously you can see this one on the right is growing out, and you can see the nail there. You can see the nail here. The other way you can tell is that when the entire bone, that articular base down here, is dissected off of the paw pad, that pad is now only covering the end of the P2. So it's going to atrophy. It's going to be small. It's going to be round if we go back to these guys here. So they're now walking on something that's round instead of oblong. So if we go to these guys here, where there's a large P3 fragment, that articular base is not cut away from it, they're going to still look normal. So these are oblong paw pads. They're not atrophied. They're not callous. They're not scarred. So if you see that in a cat that's supposed to be declawed, it should tip you off that there's probably a large piece of bone in there and it probably needs to be removed. So the takeaway from this part is the absence of visible nail regrowth does not rule out P3 fragments. And just a reminder on that last note that in this study, 63% of declawed cats radiographed had P3 fragments. I will tell you without exact numbers that the majority, meaning well over 50% of those, did not have externally visible nail regrowth. Nail regrowth confirms the presence of P3 fragments. However, the lack of visible nail does not by any means rule it out. Also in this study, the odds of back pain, periuria, perichesia, which urinating and defecating outside the litter box, and aggression were significantly increased with the cats that had fragments left behind. Not to say that those that didn't fared normally, but they fared just slightly better. Okay. These are a couple photos of some pathology that I've seen prior to surgery. A, it shows the external nail regrowth. B is swelling dorsal to the paw pad. When I cut through that, what it was is non-cornified epithelial tissue. So that yellow gelatinous stuff. Arising from the living epidermis. C is a little bit of some sub-Q hemorrhage. D, exudate from a chronically infected digit. You can also see the black arrows pointing to the paw pad, the white's pointing to the infection, obviously. So the paw pad looks pretty normal. And then E is another example of a misaligned paw pad. So the cat's walking P2 to skin to floor. A is where the callus is forming, and the white arrow is where the callus is forming, the black arrow is where the paw pad is, so it's way behind it. F is, I've seen these little pinpoint ulcerations above the paw pads, and this particular one was being caused by an osteophyte or little bony projection that was growing right off the edge of the cartilage on the P2 bone, and it was poking through the skin. So she didn't have a bone fragment in this toe, but she did have that was removed. Some of the other digits did have fragments. And then G shows some contracture. The white arrow is pointing to the toes that are contracted, where the P1 and P2 joint is just kind of frozen. It's stiff, it's hard to extend. That's not specifically it doesn't specifically point to fragments or anything like that. The other digits actually had the fragments, the ones that have normal looking paw pads, but it was of note. And then H is another example of the P2 hitting skin to floor, and it's creating a nice little callus. And this one has a high likelihood of causing a horn at the edge of the paw pad. All right, stance and gait. Palmagrade stance is definitely common in older declawed cats. I know that it can happen in non-declawed cats. I've definitely seen that. But I would say it's more common earlier in their age with declawed cats. Definitely all four. Look at the back feet too, but you have to rule out metabolic causes as well. That is irreversible, unfortunately. They'll have the short, choppy steps, walk a couple steps, sit down, and then repeat. They'll hold a limb up. Some cats will arch their back with their head down. But as far as the palmagrade and plantigrade stance, it's a tough one to treat with the ligament and tendon laxity. Back pain. That can be a tough one, identifying back pain. So the way I do it is I do light to moderate pressure. If you are pushing hard, no cat's going to like that, and you're not going to get any sort of accurate result. Every cat's going to need that. So light to moderate pressure all the way from the neck down to the tail. If you're not sure, just write negative reaction to vertebral palpation in the record and move on and just kind of monitor it. The radiographs are usually normal of the back in this situation. From the best I can tell, it is a muscular pain. They don't like their back pet or brushed. The best thing to do is to teach, especially if you're not sure if it's pain, teach the owners how to look for pain, how to look for the FAS signs and scores at home when they're more comfortable, and see if it's something that's repeatable or if it's just in the clinic. Clients are usually a little less likely to push as hard as they need to, but again, you don't need to push that hard. This is just a quick demonstration of some things that I see when I palpate a cat for back pain. I'm not pushing hard at all. It's repeatable. It's right at that tail junction. This cat was 1 year old, domestic short hair, spayed female. She just briefly presented for scratching her owner's leather couch. She wanted to declaw her, took her elsewhere, had her declawed, and then presented back to me 6 months later for peeing and pooping on the couch. And this is what we found. She is, by the way, still doing it. Okay. Overgrooming. Overgrooming is another strange one and can be related to lots of stuff, which we know in cats. Psychogenic is always the go-to if we can't kind of figure it out, but you have to rule out all the allergic things. But I've seen it a lot with pain. So they can have pain. The one on the right is showing the overgrooming over the flexors, and then the other one is abdominal overgrooming. They can be managed with medications, but you have to try to rule everything else out first. Pelvic limbs, thoracic limbs, carpus, thoracolumbar. So some cats can whip around and get to their back, but if it's painful and they're larger and they can't reach it, or they have some arthritis or something like that, they might not be able to actually overgroom the painful spot, which might be their back. Okay. This is probably the more severe one that I've seen. Sorry about the quality. It was in the days of not so great camera phones, but this one, we haven't shaved anything. She did this to herself. It was basically from her shoulders to her tail. She overgroomed, pulled it all out. I didn't have a good still photo, so Hope you can see from this video that she has pulled out all her hair and overgroomed. Let's see, we did stay in touch with this cat, and after she had surgical removal, she had all 4 feet declawed. After removal of all the fragments, put her on pain management for about a month after the surgery, and then she stopped overgrooming completely. Wish I had an after picture, but I don't. But we had stayed in touch with her, and she's doing well. Okay, just briefly remember from the initial fear-free training module that a delayed stress response is caused by cortisol release from the adrenal glands. I would classify chronic pain as a stressor. So another question to ponder is, what long-term health status or health effects are declawed cats having from this chronically elevated cortisol? Above is the list from the fear-free module of effects of chronic cortisol release from chronic stress. So, suppression, delayed wound healing, all those fun things. IBD, which we see all the time in cats. Muscle wasting, progression of behavioral disorders. Behavioral disorders that's a big one to pay attention to. And again, behavior, in my experience, it's definitely more common, it's more common to have non-declawed cats have a lower FAS score in the exam rooms. It's not common for me to have declawed cats just walk right out of the carrier and be comfortable in their situation and be at that 0 to 1. So something to watch out for. You can even have someone keep a tally in the office. Have a blinded nurse do it. Don't tell him or her why you're doing it. And see what kind of FAS scores you get with clawed versus declawed cats. Just for your interest. Okay, this is just a radiograph to show you the difference when you're looking at them, what a full declawed amputation versus a normal digit looks like. The one on the left has the P3s and the one on the right does not. And these are some photos of radiographs with small P3 fragments. So again, on the left, you can see the red lines go through the areas where I would expect that it was cut through to have these little fragments. If you can't see them very well, or you're just not sure on regular radiography, you can use dental radiography. On the right, you can see these little bone fragments that are most likely the flexor tubercle or the whole articular base of the P3 bone. And then some larger ones, you can see with the white arrows. The one with the red arrow has the abscess. We saw that earlier. Those are usually guillotine, usually, not always, but the red lines kind of show you the areas that they're cut through. All right, just a brief on medical management. If the cat has fragments or you're noticing pain, whether it's back pain or actual pain in the digits, the joints, something like that, it's kind of the same as it is with arthritis treatment in cats. Can use Onsior, buprenorphine, amantadine, gabapentin. I usually start with Onsior for 3 to 6 days and gabapentin, and then continue with the gabapentin long term. And you may have to go up or down on the dose, depending on how they respond to it. Some alternatives, joint supplements can sometimes be helpful. Adequate injections, acupuncture, depending on where the pain's at. Therapeutic laser, CC loop, all of those things can be helpful as well. Okay. So this is the first one here. This particular cat didn't have P3 fragments. However, she was showing signs of some chronic pain. The complexity of chronic pain and classical conditioning in this cat's a little probably beyond the scope of this webinar, but consider it in this case. She's learned that she doesn't like being pet on her back. And on intake, the rescue, it was difficult to tell if this was true pain or it was perceived pain in the past that she was conditioned to be fearful that was coming. So we needed to aim for counter conditioning by managing the pain and slowly allowing them to relearn and trust again. The first video is in a room she is familiar with. So I can play this. Person she's familiar with, no other animals prior to any veterinary evaluation or treatment. They're not really sure what the problem is yet, so they're still touching the back, and that's usually her response. And then the after, the second is on medical management, which is gabapentin 50 milligrams by mouth every 12 hours. In a different home with a new owner. The second person has avoided touching her back for a length of time, counter conditioning by giving attention at the cat's request, food, treats, etc., and then gradually petting her lower back when she is happy instead of already stressed. So she is doing well, a lot better these days. Our surgical management. This is these are a couple of pictures of a couple of things that I've seen while trying to remove the fragments. There are, I've completed upwards of maybe 100 surgeries on cats, cat digits post declaw. Most common for me is just the removal of the P3 fragments, but like the bottom, looks like that picture didn't show up. Okay. The bottom left picture is removing some osteophytes or bony projections that kind of grew from the chronic inflammation around the P2. Other indications are to remove the osteophytes, repositioning digital pads, debriding the necrotic tissue or chronic wounds, removing calluses that are painful. Sometimes you just have to explore the digits. You can tell that they're painful in their toes. You just don't know why. So some of these, I couldn't see anything on radiographs. I just explored the toes and this is what I found. Not necessarily the top one. That one was a little more obvious, but in some cats that have, really contracted digits, again, tenectomy is always an option for these declawed cats with no other pathology. I've never had to resort to that. They can leave them flat-footed, but that is technically a salvage procedure if there is pain that we can't handle with medical management. All right, surgical candidates. Looks like I have a couple chats here. I'm gonna go to that real quick. Respectfully, this is neuropathic pain, not musculoskeletal. Okay, yeah. Neuropathic pain, fair enough. Okay, surgical candidates. Even if a young cat isn't showing signs, but has P3 fragments, removing them early as they heal much better is definitely better than waiting. If they're 12 and limping and they have an abscess like this cat, it definitely complicates the situation. As far as evaluating them prior, definitely don't skip the pre-anesthetic blood work. Consider adding in a pro-BNP, especially for older cats or those with infection like this one. Consider the benefit versus risk. Older cats, it's a tough surgery, so it's definitely involved, and there's a lot of post-op management medically, so it definitely needs to be looked at. Okay, anesthesia. I won't go into this too far. Everybody kind of has their own anesthesia protocols, but this is what I usually use. If they're really young and healthy, sometimes I'll substitute ketamine for midazolam. But pre-med induction, lidocaine on the retinoid cartilage is maintenance. Monitor, pay special attention to the body temperature. They can get cold when you're working with their feet, and their feet are being scrubbed and they have alcohol on them, etc. Pain management, I do 4-point distal limb block with bupivacaine. That procedure can be found, it's Enomoto et al. I put the paper link there. That's the best way I've learned to do it. I use Symbidol injections, sub-Q at induction, and then every 24 hours for 3 doses, and they stay in the hospital the whole time for 3 doses. So that's 2 nights. Onsior sub-Q injection at the end of surgery. I just have a phobia of giving it intra-op, and there's a blood pressure drop. Whether or not that's an issue or not is it's possible that it could be. So that's just how I do it. Buprenorphine after the Symbidol is done, I continue it for another 3 to 6 days. It depends on if it's all 4 feet, if it's just the front feet. Onsior, 3 to 6 days, once a day. Gabapentin. I usually do gabapentin for 30 days, honestly, at least. Sometimes it'll be 60 days. It depends on how bad it was and how difficult the surgery was. Okay, surgical prep. In my experience, it is difficult to shave as expected for other surgeries, given the loose skin, the small areas. We shave the best we can without causing clipper trauma, and then scrub normally. Removing the fragment. Let me just mute this. Okay, so you're going to start making an arc incision. So anyone that has declawed, this probably isn't life shattering or shattering for you, but if you have never declawed, I'm going to make a little arc incision above the paw pad. The first thing you want to do is find that joint. So find the joint between the P2 and the P3 if there is still a joint present. You just kind of have to dissect away until you can see that shiny part. I don't know if you can see my cursor, but right there. Yeah, right where that arrow is. That's the end of the P2, the cartilage. So you just want to dissect the skin and the sub-Q tissue away from that so you can see the whole thing. In this cat, the articular base was attached to the deep digital flexor tendon. That's the edge of it right there. So cutting through the deep digital flexor tendon and then just gently dissecting it off of the paw pad. So this is a smaller fragment, and this cat had them in all toes. That bugger can be hard to hold on to. Okay, and there's that one. And then here is another one. Similar. It's a little bit, this fragment's a little bit larger than the previous one. It has non-cornified nail tissue growth under the skin. It's that yellow gelatinous stuff. Many times you have to dissect through a lot of abnormal tissue to find the landmark of the P2 cartilage, and it can be, they're all different. If there's a lot of inflammation or there's a lot of abnormal tissue growth from that living epidermis or that root of the cornified claw sheath, you will have some interesting things under that skin. All that stuff right there, that's the non-cornified tissue. Like I said, you'll have to excuse the lack of shaving because we didn't, it was tough. It's tough sometimes to shave without causing clipper trauma. Sometimes you just got to do the best you can. And there you go. So that one was buried a little bit under there. That right there was the joint of the P2 and P3. Right there. Okay. So that was just dissected off the pad, kind of like the other one. Oh, right. That was a pelvic limb too. So hind leg. And then the alignment of the paw pad. There are a couple different ways you can do this. On the left, it just shows kind of a sequence of events doing like a purse string, starting with just the tissue around the end of the P2. So you can do kind of a purse string around the end of it to cinch it down, or you can just do one. Seems to also be pretty adequate, but sometimes there's a lot of dead space. You have to remove some tissue, and it may be more helpful to have a bigger anchor. You just have to try it. This is showing taking a bite through the paw pad, and then another pretty generous bite of the subcutaneous tissue above the P3, just to give it an anchor. I'm sorry, above the P2. The suture I use is the generic Vicro-Rapide 4-aught. It's soft. I started using monocryl 4-aught, but it was too stiff and it was irritating. And the cats hated it and they would chew it. So I use Vicro-Rapide, or the PGA Swift is called, I think. It's the generic. This was kind of the same as earlier. The exudate, the little bony fragments. This one in the upper left was pretty remarkable. A lot of bone pieces. That was all cornified. So that was all hard nail growth under there. So it's just a couple pictures of what I've removed. Even if you see one digit on the radiograph that looks clean and all the other ones don't, explore it anyway. If you have 4, chances are there's going to be 5. There's very, very little chance that there's going to be one that doesn't have anything. Sorry, there's a question. I do use a curved blade to get behind the P2 and P3, the 15 blade. So I use the curved edge of it. I think that's what you mean. But yes, I do use a 15 blade and the curved edge of it. Okay, this I have never recorded myself doing the wrap at the end of the surgery, and I realized that a couple days ago. So we're gonna use a stuffed animal to show you how I wrap the foot at the end of the surgery. I just use I think it's a 60cc tube, 60cc syringe tube. I put 2 gauze on it. It works super well with the stuffed animal cap. I get the idea. Works better on a real cat. Pull it up to above the elbows and then some tape. I do not use glue when closing the incisions either. When sutured, I also tried glue and it did not go well. So I will tell you, don't do that. The post-op wrapping I leave on overnight, take off in the morning. If you don't have tube gauze, you can just use regular gauze too and kind of fashion something like that. And let's see here. Okay, recovery. I use shredded paper for recovery. We have plenty of it since we're shredding everything in the clinic. 2 to 3 days, at least while the cat's in the clinic. Follow up with owner is definitely needed to assess pain management at home. Give them a scale to look at, ask them questions about movement. You have to stay on top of that because it could cause further pain down the road. There's no need to remove the sutures. They will dissolve. They'll go away on their own. Cat will pull them out when they need to be out. I've never had any cat, knock on wood, pull them out early. I highly recommend continuing gabapentin for minimum 30 days, minimum. I only had one cat that reacted negatively, diarrhea to gabapentin, so we used amantadine, and that went great. So one of the two for minimum 1 month. Recovery. This was an abstract published in JFMS in 2020 with regard to the P3 fragment removal findings and replacing the paw pad. So the follow-up wasn't great, but long-term, greater than 6 months, post-op follow-up was available for about 38 of the 83 cats. And a lot of the behaviors improved. They did not disappear. So it's not going to fix everything, but it did improve quite a bit. So the peri-uri improved, 10 out of 16, biting improved 5 out of 9, aggression improved in 7 out of 9, and the barbering or overgrooming improved in 4 out of 5. So it does help. It's not going to help every single one. The fragments are not the reason for all the declawed cat problems, but it is something to pay attention to. Prevention, that's pretty simple. Let's not declaw cats anymore. We can avoid all of this mess. Okay, here's a couple cases real quick for you. This is Zuri. She was a Savannah, I believe an F2 Savannah, 3-year-old, spayed female. All 4 feet were declawed. She was surrendered because she became less social. She had very large P3 fragments with nail regrowth and all the digits, and she was quickly adopted, and I have not heard of return yet, but this was her walking. This is Zuri. I guess you can hear it. She would hold her feet up like that. She would stand with shifting leg lameness on the front. And then the picture on the right, you can see some nail regrowth. She did not like being touched at all. He's a beautiful cat. And then I only have part of her surgery, but you can at least see when we cut through what it looks like. So again, you attempt to make that arc incision above the paw pad to give yourself some skin to suture back onto when you're closing. This looks like it was a hind foot. Again, don't mind my lack of shaving, but that was a tough one. There was a lot of swelling. And this one, it was just kind of had to explore and dig through the abnormal tissue and try to find that P2 cartilage. Getting there. That on the top and the bottom, that's all non-cornified tissue growth from the living epidermis and the root. There, I found that joint space right there. And try to work the blade in between it to cut those there's collateral ligaments and a deep digital flexor tendon. So you gotta cut the collateral ligaments first if it's that much of a joint space that's still left, and that will release it a little bit, and you can pull it and find the flexor tendon and cut that out. This is what her fragments looked like. Okay, Jerry, I think we just had a couple. Jerry was a 5-month-old neutered male, domestic longish hair, long to medium hair. He was front declawed. He had a history of chronic digit infection. It's the one with the abscess that we saw earlier. He had large P3 fragments on all digits. He had been on lots of antibiotics for a long time, and it was not getting better. So they came, it was a second opinion. We took x-rays and or radiographs, and that's what we saw at the bottom. So submitted culture and sensitivity, treated with antibiotics for 2 weeks until a lot of the exudate was under control. Then we scheduled for surgical removal. CBC chemistry were normal preoperatively. Other than the digit infection, there was nothing else, no murmur, heart sounded great. Patient arrested under anesthesia soon after intubation. We had the referral lab, and we woke him up, got him back, he's doing fine. Had the referral lab add on a pro-BNP to that pre-anesthetic blood work, and it was 700. So everything looked okay from the outside, but he had a cardiac condition. The radiologist that looked at his echo suspected bacterial endocarditis. So this cat potentially had bacterial endocarditis from this chronic infection. So luckily we have some excellent nurses and their monitoring skills. She immediately saw that he was not doing well. Reversed everything, woke him up, got him on oxygen, did CPR. He luckily is okay. And yeah, I guess that's it for him. He eventually came back and we did the surgery, and below is what we found. That arrow is pointing to the one that was abscessed. You can probably see the one above that too, pretty nasty. So, summary. Went through the anatomy, that root of the cornified claw sheath, the articular base, and the ossification. Those are the main takeaways on the PE. Look for nail regrowth, but it doesn't rule anything out if you don't see it. Limb and back pain, look at their gait. Radiographs, you're looking for fragments. Medical management, with or without visible pathology, you can manage their pain in a lot of different ways, and it will help. It'll help in the long term. Surgical intervention, remove the fragments if they have them, address any other pathology or source of pain that you can surgically remove. If there's osteophytes, remove them. If there's infection, treat it. If there's something that's not supposed to be there, take it out, cut it. And then prevention, simple. I would just don't do it. Don't declaw. So that is everything. So I am always available. There's my email. If you want more info on the PAW project, I do work with the PAW project. I'm one of the Texas state directors, so I'm a resource for those in Texas that need it. If you need some alternatives to declawing, there's a link there for you. And I think that is pretty much it. Appreciate y'all hanging in there. There's a lot of info. I skipped over a couple things, but you can go back and look at it at your leisure.
Wonderful. Thank you, Dr. Moran. Yeah, as she mentioned, this will be, you can come back and look at this later. This will be posted on fearfreepets.com for later viewing. So we'll move on to the Q&A portion. If you have any questions that you think of, go ahead and put them below. I'm going to start going through them now with her. I have a question, Dr. Moran, from Leah. If the cats develop osteophytes from the chronic inflammation and the osteophytes are removed, would you expect them to grow back at some point?
It's definitely possible. I have not had to, I've lost a lot of cats to follow up just because a large portion of them were in shelter situations. So I've not had any owned cats come back with osteophytes that reappeared. It's definitely possible though.
Okay, thank you. Next question is from Megan. Hi, Dr. Moran, fourth year vet student here, interested in becoming an ABVP diplomat in feline medicine. Do you ever use meloxicam at the 0.05 milligrams per kilogram dose long-term for pain in these kitties?
You can. I prefer Onsior. If you only have Metacam at your disposal, I would recommend going even lower than that if you can. The lowest effective dose. I usually start even at the 0.025 mg per kg. In old cats, if they have kidney renal insufficiency or something like that, even lower, 0.01 to 0.02 mg per kg might also be called for. Like I said, though, I do prefer Onsior, but if that is not an option, you can use Metacam. You just have to be really careful, check the kidney function, and stay on top of it.
Thank you. I have another question from Leah. You do not use a tourniquet in the surgery, correct?
I don't. Well, technically it is classified as a tourniquet, but we just use a rubber band with a hemostat. It's not very tight. If there's a lot of inflammation, they are going to bleed a lot. So you might have to use a tourniquet above the elbow. It just depends on what you're seeing. If there's a lot of bleeding, you may have to, because more bleeding will cause a lot more bruising afterwards. It'll be painful. But we have just used just a gentle rubber band with a hemostat to hold it around the elbow, and that seems to be adequate.
Thank you. It looks like there's a question came in on one of the last ones. Can you use Onsior long-term if you do not prefer meloxicam?
Yeah, it's, we know that it's off-label. It's not labeled for that use, but I do have a lot of patients on Onsior long-term. I try to get them again to the lowest effective dose. So if we can do, if their dose is 6 milligrams daily for 3 days, I do that and then try to go down to 1.5 if I can. If they're still doing great on 1.5, I'll do 1.5 every other day. Or you can do 6 milligrams. I'm sorry, if you give a 6 milligram dose once a day for 3 days, you can cut it in half to 3 milligrams every day or every other day. So it's a lowest effective dose. If they have renal insufficiency, you may have to kind of play with it and go at a lower dose. Definitely keep up with their renal function. I have seen renal function compromised with long-term Onsior. So you just have to be careful.
Okay. There was a note from Dr. Downing. She says to please see the consensus guidelines from the ASFM, WSAVA for details about meloxicam in cats. Just an addendum to that. Sally asked, do you ever leave the surgery site open for healing, or do you always close it up?
I don't, because it is usually large. Unfortunately, you do have to make a large opening. So it's a little too big for second intention healing, especially if they're walking on it. So I do not, in fact, I try to reduce as much dead space as I can. So sometimes you either have to remove some of the skin around it to remove the dead space, or you have to take just really large bites with the suture to help with that as well. But no, I've never leave it open.
Okay. Mentioning the suture, there's a question. What size suture are you using for closing after revision?
It is 4/0.
4/0.
4/0 Vicryl Rapide, or the generic is Swift, PGA Swift.
Okay, thank you. Let me just go down here. Another question from Sally. Has anyone traced if these problem declaws were by the nail clipper method or curved blade technique?
The data was not available on every single cat, so it wasn't something that I could consistently say. I mean, the larger fragments are definitely more likely from guillotine nail trimmer methods. The smaller fragments can be anything. They can be from guillotine, they can be from blade, they can be from laser. Like I said, that bone doesn't start to ossify until they're 6 months old. So if these cats are getting declawed when they're getting spayed at 4, 5, 6 months old, they can definitely cut through that with a blade.
Thank you. Question from Deborah. Do you only recommend antibiotics if there is gross evidence of infection when doing the salvage procedures? We always recommend.
That's a definite yes. You know, when you see exudator infection, definitely use antibiotics. But if it's a couple digits, I usually don't. If it's all the digits on all the feet, then yes, I will use antibiotics as a preventative, because it's not, I mean, it's the feet, and the feet get dirty and they're in the litter box. And so yeah, I do use antibiotics if there's a chance they're going to get dirty, if there's more than 1 or 2 incisions.
Okay, thank you. Let's see here. A question from Susan. Where were you trained on declaw procedures, and what made you interested in doing the paw repair surgeries?
That's a loaded question. I received one brief lecture in vet school on declawing. And then when I was the first 3 to 4 years out of school, I just declawed cats, both with laser and scalpel blade. And then about four years out, I never liked doing it. So I just tried to find information on why I shouldn't be doing this. And that's when I started to get involved with the paw project. And Dr. Conrad really, helped me have the confidence to say, I'm not going to do this anymore. And that's okay. And it's good for the cats to not do this. So finding that confidence was part of it. So I already knew how to declaw, but I was starting to see these cats with problems. I thought, well, I'll just try to remove what's in there. And then, over time I got to, 100 of them, and I just kind of developed my own way of doing it. So it was not really something that anybody taught me how to do per se, just experience and what worked and what didn't work.
That's good to hear. Thank you. I have a question from Susan. I see adhesions of the P2 to the pad, which results in pad attenuation under that spot. Is there any way to correct that? What about when the bone is next to the pad? That's in chat if you need to refer back to that question.
Gotcha. You can, you can always go in and remove the adhesions and try to better place the paw pad over the end of the P2. It can get difficult when they're really atrophied and tiny though, because if they're not walking on them at all, those are going to atrophy to even smaller than what's on the end of the P2 bone. So that can be tough. You have to kind of stretch the skin a little bit and pull it up over the bone. So it can be done. And that may help them in the long term too, especially if they're getting lots of calluses on their feet. You just kind of have to weigh the pros and cons. Can the cat tolerate this kind of surgery and aftercare? If not, then you may have to, figure out a medical management procedure.
Thank you. Have a few questions from Mary have come in. Do you have any statistics on all declawed cats that have problems versus the second opinion referrals? Not sure if you've seen.
I'm sorry, I didn't hear the last part.
Says her question was, do you have any statistics on declawed cats that have problems versus the second opinion referrals?
In the paper referenced earlier that I wrote a couple of years ago, the population was any cat that came in. We saw a lot of first opinion cases in that practice, and they were all for wellness, they were for grooming, dental cleanings. They did not come in for problems having with their back, with their toes, with anything. So all of those cats were coming in for just wellness and annual, and every once in a while there was one that was a second opinion, like the one with the infection. But 63% of those cats had bone fragments, and lots of them were urinating and defecating outside the litter box. Some of them were aggressive. A lot of them had biting behavior. So, you can go back to that paper too, and it does have statistics in there about that.
Okay, yeah, Mary. As we mentioned before, you can watch these webinars back on fearfreepets.com if you want to refer back, or you can reach out to Dr. Moran on that email that's on the presentation right now. I think that's it. It looks like, okay, we have one more from Mandy. Based on the surgeries you've done so far, what is something you would like to tell your previous self when you first started salvaging declaw surgeries that you may not have known or would have helped you?
Definitely just forget the glue. And the suture material. We're kind of they beat it into our heads that, it has to be monofilament. But it hurts the cats. It's irritating, it itches, it's picky. So I did have cats try to chew at it. I know it goes against every fiber of your surgical being to use a braided, soft suture in skin, but the cat will be happier. You'll be more satisfied with the outcome. So the suture, don't use glue, and no, the client's not going to like that. Cat's going to have to be on gabapentin for 30 to 60 days, but just hold firm. Hold firm. Hi, so there was one more question that I wanted to address after the fact. So I had a question about fentanyl, and I just wanted to say, yes, I have tried fentanyl patches. I have tried a fentanyl CRI for pain management. I haven't had great luck with them. In my hands, the fentanyl patches were a little unpredictable. Cats would get them off at night, scratch at them, break them open, that type of thing. So I don't use fentanyl patches. And then with the CRI, again, they're in our hospital overnight, so there's no one to monitor the CRI pump. And I did try it one time and it stopped and I felt terrible. So I just go with the injectable Symbidol every 24 hours for 3 days and keep the cats in the clinic. But if that's something you're comfortable with and in your hands it does better and is more reliable, then great. Just use what you're comfortable with.
Thank you so much. Looks like we're at time. Absolutely wonderful presentation, Dr. Moran. I've seen a lot of people in the chat here saying it's one of the best webinars they've been to in a long time. So looks like everyone really enjoyed it. It's wonderful having you here. Again, everybody, this will be posted on fearfreepets.com. If you have any questions for Dr. Moran, you can see her email there. And then if you have any questions for us at Fear Free, please don't hesitate to reach out to us at wags@fearfreepets.com. Thank you for joining.
Yeah, thanks everyone.